So she was diagnosed with scoliosis. Now, what kind of scoliosis is there? There's what and what?
Functional,
And,
structural.
okay, so which one's what?
Well, this is called a functional.
Yes. Okay, so functional is a result of asymmetry, bad habits. Structural is what? You're born with it. You actually have a misdevelopment. You actually have certain ribs that are overdeveloped. You have a spine that literally starts to rotate and fuse as you get older. Very easy to diagnose one versus the other. Very easy to see. But oftentimes we do misdiagnose, as far as I'm concerned, what the true scoliosis is. Okay? So that's one. This is another one. Whoa. Whoa. There. That's another one. She was diagnosed with scoliosis. She's a 16-year-old girl. She's a swimmer. Right? That's her before and after picture on her first session. Here's my point. I don't care whether it's functional or structural. Obviously, somebody who has functional scoliosis is a lot easier to solve, right? Because it's more of an action-reaction thing in muscles, and we can train it and pull the body back in alignment. But what can we assume about somebody who has structural scoliosis? Okay? What else can we... How much compensation do you think they're going to have? A ton. Can we still get rid of that compensation? Yes. Can we get rid of the actual scoliosis? No. Unless we get it early, right? Before their growth plates close.
So in your opinion, the structural, did it start with functional first and then move into structural? Or do you think any of it was already?
I think that everybody has functional scoliosis to some degree. Every single person that I see has functional scoliosis. Why? Because my party trick is every single one of you here has an elevated hip. And you weren't born with it. It's just because of dominance and injuries and everything else that you've accrued. Everybody here has an elevated hip. Stand up. Come over here. It's the way she dances? No, because she drinks too much alcohol. That's what. Okay, so there's the top of her right ilium. There's the top of her left ilium. Which hip is higher? The right. Okay? You can visually see that. Every single person has an elevation in the hip. What is that going to do to the spine? It's automatically going to laterally shift it somewhere.
Can you fix me?
Yes. So here's my point. Now mix in structural scoliosis. So you've got functional scoliosis because they're going to have that anyway because of life. Mix in structural and it exacerbates it. So when I'm measuring people, when I'm measuring actual people with scoliosis, with structural scoliosis, yes, they have an offset and they have everything that is clinically scoliosis, but what else can we assume with that? Is that there's a whole percentage of compensation added to that that's regular functional scoliosis. So what I tell people, especially if they're after age, if they're after 20, 21 when they've stopped growing, is no, I'm not going to fix your scoliosis, but I'm going to make it better in that I'm going to get rid of your functional scoliosis. And whenever we measure somebody with true scoliosis, they're just exacerbated based upon a normal functional scoliosis because usually one hip's really elevated and usually one hip is really anterior. Almost every scoliotic person that I've met that's older and I measure them, they usually have one hip that's right 19 or 20 degrees from PSIS to ASIS. Huge anterior. So I want to minimize that as much as I can to minimize the effect of the structural scoliosis. So I'm never going to tell people I'm going to just get rid of their scoliosis, but what we're going to do is get rid of the side effects of the scoliosis. Unless they're young enough, I still believe that we can reverse it to some degree. And I've proven that. We have a lot of teenagers that I've worked with. There's another before and after picture of a girl in San Diego who's 14. And she was clinically shown that her scoliosis was better from x-ray. Now, she'll always have it, but what we want to do is minimize it as much as we can and then do what? Stabilize it. We want to stabilize it, right? Because if she goes through life and she doesn't do anything to help it, then it's going to do what? It's going to go back. Do I believe in braces for scoliosis? Yes or no? No, I don't. Do I believe in orthotics? No, I don't. Now, that doesn't mean that people shouldn't wear orthotics, but only until what is addressed? The original problem, the original pattern. If we can get rid of as many compensation patterns as we can and then throw orthotics, then we're good. But if we give people orthotics and not address the overall dysfunction, then all we're doing is doing what? We're just putting a crutch in the body, and we're not allowing the body to actually, and this is what I do. One of the things that I ask in my medical history form that you guys filled out, right? Do you wear orthotics? And so what I'll do is I'll take people through a first session. I'll take all their measurements before, take them through the routine, take them after, take the measurements again, and see that we've corrected things to a certain degree, right? And then I'll say, put your orthotics back on. And then I'll measure them again. And what am I looking for? So what typically happens? They go back to the original measurements because the orthotics were prescribed based upon what body? The crooked body. So my whole philosophy is let's change the body as much as possible and then do measurements for orthotics. So I'm not against orthotics. I'm just against orthotics the way that they're given typically. Because we still want to stabilize on some level the feet because the feet end up collapsing, which is a whole other topic. Does that make sense? So it's just about getting them to participate, to fix their body, get them as aligned as they can, and then we can start playing with gadgets.